So let's see. So again, welcome everyone to the MSDHA lunch talk with Dr. McCulloh. We're super excited to have him here and to share his experiences with us. So I'll just do a really quick introduction and then I'll pass on to Dr. McCulloh. So Dr. McCulloh is a pediatric surgical critical care fellow here at Michigan. He received his medical degree from Case Western, moved on to general surgery residency at Morristown Memorial Hospital in New Jersey, where he did a, thank you for whoever added captioning. And he did a postdoctoral research fellowship. During that training, I believe he moved on to a pediatric minimally invasive surgery fellowship at Nationwide Children's Hospital in Columbus. And now he's at Michigan. So I'm sure there's a lot more details there, but I'll pass on to Dr. McCulloh to fill in the gaps and share with us what you have.
Sounds good. Thank you very much. Yeah, I guess I came to my senses and came from Columbus to Ann Arbor. So, I do want to thank you guys for the opportunity to speak. I don't know too many organizations like this sort of at the med student level, and I think it's one of those things that's really needed. So I think it's really great that you guys are starting to put these things together. And then you guys can sort of continue on and take the knowledge that you gain here to the rest of and share with the rest of your colleagues. If there's any questions that anybody has, at any point after the talk, you can feel free to message me. My email is in the directory, of course, or I'm, pretty active on Twitter too. So just a little bit about me. Kate already gave a pretty good overview. Pediatric surgery, for those who don't know, is a ridiculously competitive surgical fellowship to match into. It's pretty much considered the most difficult of all. Coming into that from a residency program that's not a big, huge academic place, and also, to be frank, as someone who's disabled, which they've never experienced before, has been quite a challenge. So that's a bit of a reason for the long training road to get where I am now. But I did finish, residency. I'm a board certified general surgeon at this point, and I'm in the middle of my second round of applications for pediatric surgery fellowship. So I'm just finishing up interviews, and our match day is in May. So I'm kind of getting to the same point as a lot of you guys are with respect to next week. So what I kind of like to do is just talk a little bit about my own experiences as I've gone through this process, and then also share with you stories of other people that I've spoken to over the years. I've been lucky enough to talk to a lot of other people who've gone through the training process or currently are going through the training process. So I think that there are a number of challenges that are both physical and then non-physical that disabled people tend to face when going through the healthcare system, and then also going through the education system. And I think as physicians, we're sort of able to be some of the strongest advocates for all of them. So I kind of, in speaking, I hope that that's something that is something that you guys are able to do as well. I think, as you guys know, there's not much education at all in medical school about interacting with disabled patients or just sort of the day-to-day. So it becomes something that we tend to learn on the fly. In my own story, we always, in medicine, we talk a lot about the Swiss cheese model of errors where, everything has to line up in order for a certain error to occur. And I've been fortunate enough that my story is kind of the opposite of that. And I've had everything line up just right in order to make things happen. So I grew up in Manhattan, born and raised in the city. I was a strong interest early on in both medicine and technology. So I think, like a lot of people, I was a hospital volunteer and an EMT in high school. But I was interested in surgery even from a young age. In fifth grade, my best friend's dad was a plastic surgeon, and we used to find in his office, he had these recordings of open heart surgery. And there we were in the middle of the summer watching these videos, thinking it was the coolest thing in the world that you could operate on somebody and not only not kill them, but potentially make them better. But I did have an interest in technology. I was working in the internet industry in the late 90s. I sort of used that to pay my way through college. I managed servers for a bunch of .coms, and then actually ended up creating my own business, which is what really helped me to pay my way through college. I started off as a bio major at NYU. And I remember sitting in my the first day of my second year of classes, and I think it was like an evolutionary biology class. And I just thought, like, I don't want to spend the next couple of years studying this stuff. Like, it wasn't kind of what I was interested in. And everyone said, study what you love and do something you enjoy. So that's what I did. And that's where I wound up in computer science classes. And to abbreviate the story, after we created our own business, we did information security consulting. I was contracted to McDonald's, and I was an expert witness for the United States Department of Justice, and got to do all this really fun stuff and travel the world. And I lived in Munich for 6 months on somebody else's dime. But the plan was always to go to medical school. So I always kind of knew I'd go back at some point. And then I was on a business trip, and I had a very fortunate conversation with a guy on a plane. And that night in the hotel room, I registered for to finish the last of my classes and get ready for the MCAT. I applied early. I interviewed early at several places, and Case Western was kind of one of my top choices. I got an acceptance on the first day that they put them out in September, and I was like over the moon. I was super happy. I started getting other acceptances. I was working, managing a team of engineers, and like life was great. I finished college. I was just enjoying my life, and you can kind of guess what happened after that. In Sunday of 2008, I was living in the ground floor garden apartment of a brownstone in Brooklyn. And I'm 6'3". I'm not a small person. And I slipped and kind of went up and came crashing down. And my neck landed on the edge of a very thick glass coffee table. And it snapped back, and I was knocked out for about 10, 15 minutes or so. And when I came to, I was lying on the ground, couldn't move my legs. And I just, I remembered all these, I thought, how could this be happening? I must just be stunned. And then, oh God, please don't let me be paralyzed. I'd rather be dead than paralyzed. So after I sort of got my wits together, I was home alone. So I was able to use a power cord to pull my phone over to me. And I called my partner at the time, who had keys to my apartment, and she was able to come over and unlock the wrought iron gate that EMS never would have been able to get through, and called the ambulance. And then they took me to the hospital, and they found that my C7 vertebra had come completely out of my spine and was actually lodged between 5 and 6. So my spinal cord was kind of making a big loopy figure 8. Which it turns out is actually, a stretch injury like that is better than, a transection or anything like that. So they took me to the OR. I was in there for about 7 or 8 hours. They flipped me over in the middle of the case. I had an anterior and a posterior cervical fusion. And that was the only way they could get my spine to sort of line up properly and stay in position. I was in the ICU for several days. So I kind of understand a little bit of the ICU delirium, because at one point the pain was so bad that I actually tried to rip the IJ line out of my neck, because I thought the only way they're gonna, they weren't giving me additional pain meds, and the only way they're gonna understand how much this hurts is if I show them. That was what made sense to me at the time. But they did, and they upgraded me from morphine to Dilaudid, and I felt a lot better. And, and fortunately that I ended up getting what I needed. But after I had fevers for about 9 days, felt like it was something like 9 years, and then I was transferred to rehab. I chose Mount Sinai because it was in the city. It was close to family and friends, and Mount Sinai was part of what's called the model system for spinal cord injury. And this is kind of one of those places where I think it's really important to be able to advocate for patients, and that's getting access to care. Model system participants basically are engaged in a certain degree of research. They're sort of cutting edge. They're engaged in helping to define the progress within the field of spinal cord injury research. Sounds great. There's only 14 of them in the entire country. So you can get great rehab at other places, but access to people who are actually doing that research and defining those protocols really makes it's a real advantage. And I was very lucky to have that. But I was worried. Was I even going to be able to go to medical school? Forget about being a surgeon. You have to stand if you want to be a surgeon. But I was lucky that I had my physiatrist, who was my inpatient physician while I was at Sinai, also happened to be on the admissions committee of their medical school. And so he said, why can't you still go to medical school? You could still be a doctor. And so I'm like, all right, well, maybe this guy knows what he's talking about, but he's not a surgeon. I still couldn't possibly be a surgeon. And so they had this wall of stories, which I thought was really, as somebody going through a new injury and this, really big life change. I really thought that was one of the best things I felt about the rehab facility, is all these stories were different people who had been injured and had become, had still done what they wanted to do with their life. They'd still been productive and successful. And it kind of made you realize that it's not the end. So there was one person who was a neurologist, practicing neurologist at Cornell. So then it sort of really got in my mind that it was still possible. But still, one of my good friends, his wife was a general surgery resident, and she was the first person who said, if you can get to the table, you could still, and your hands still work, you can still operate. But it's one of those things where until you actually see somebody, you see representation of somebody who's been in that situation, who's done it, it's very hard, I think, for anybody to imagine themselves in that position. But I got lucky and I found this guy. So this is Peter Galpin. He's a plastic surgeon in Hawaii. He actually just retired within the last year. He was injured in the late 1970s, which none of the adaptive equipment that we have now was available. He got into medical school. He was injured in a motor vehicle accident. He had to have all his equipment custom made. So he had to hire a mechanical engineer to custom build a standing wheelchair for him. And he saw notes in his chart when he was in rehab that basically said he's delusional. He still thinks he can be a doctor. And I'd like to say that attitude is completely gone these days, but it's not. And I can tell you from my own experience, it's not. My uncle went through a similar story. My uncle is a neuropsychiatrist, and he has retinitis pigmentosa. So he was expected to be completely blind by the time he was around 40. And he had to apply to medical school 3 times. This was similar time in the early to mid 80s. And after his second attempt, somebody finally told him, hey, this person who said they were going to write you a letter isn't doing you any favors. They wrote in their letter that you're going to be blind by 35, so they should just not admit you to med school. So and this person said, sure, I'll write you a letter. So after he got rid of that one and applied, he ended up getting accepted to medical school. And ended up to go on and be, the chief medical officer at his hospital up in Maine. And he's been wildly successful. So I reached out to Dr. Galpin, and he told me about what he had done to get him to where, to be successful and to be functional. He was really, really persistent. Everyone along the way told him he couldn't do it, and he just kind of kept ignoring them, which is kind of what I've always tried to do. So I deferred entry to medical school for a year. I focused on rehab. I didn't want to make a lot of changes at once. And the idea of going to medical school about, 6 months after this brand new injury, when I was still just trying to learn how to function in the world, was just way too much. So I deferred entry for a year. I got some function back. My injury is an incomplete injury, so I do have some limited use of my legs. I will tell you just from my own experience, I always remember leaving the hospital, and the first time I was in inpatient rehab for about 3 months, and the first time people go home from the hospital after that, it's terrifying. You go from a place where you've got nurses and you've got, support staff and everybody around you 24/7. And the first time you go to bed in your own house with nobody else around, and God forbid something happens in the middle of the night, that's a very scary thought. So I think that's important to remember when, patients are going home after a major life, event. I had really good, when I got to med school, I had people who were really great as far as advocacy. Actually funny, last time I gave a similar talk earlier this year, and both of them showed up at the talk. But the guy on the left is Kent Smith. He was my dean when I was in medical school. The guy on the right is Greg Nemanitis. He was a physiatrist at Metro in Cleveland, and now I think he's the the head of PM&R at Cleveland Clinic. They organized, and what I think was really helpful is they organized meetings about 6 to 8 months before I was to start at CASE. They pulled in the deans of the school, they pulled in facilities engineering people, they pulled in senior people from the rehab department, and everybody to come together and sort of say, how is this going to work? How are we going to do this? And that's kind of one of the keys, I think, when advocating for anybody, which is just open lines of communication are the most important thing. And a lot of times people can be hesitant to open that conversation if they feel that it's, politically incorrect or whether it's a charged topic. But to not ask those questions and to not engage people and say, what do you need? What can I do better? How do we make this office more accessible? How do we, for medical students and students, other health profession students, what can we do to meet their needs and enable them to be successful? That's what these two did. And they were, from the very beginning, they were just open to dealing with disability. I think a big part of this was Dr. Nemanitis, and I always make a plug for him, which is, I thought, he invited me to his house. He had a second look dinner at his house with me and other med students, other applicants. And I thought he was just like, wow, this guy's really great. He really wants to see, somebody who's a patient of his succeed. And then I just found out that's just him. He does that for everybody. He's a very quiet, kind of unassuming guy, but he really cares about all of his patients. He even put together a device that I used in anatomy lab, which was, it had a clear top, which would go over 2 support sort of bars that would enable me to actually do dissections in cadaver lab. So he also was the person who put together a grant that went to the Nielsen Foundation. And this is a group that does funding for, disabled projects and in different, they provide funding for individuals and then also for organizations. And we put together funding to purchase a standing wheelchair that would be used in the university at CASE for students who needed it to continue and participate in their medical education. And we got the grant, and then that chair still lives at CASE. So they have that, and they've made it a part of their curriculum to be able to work with students who are with disabilities. And that chair is the reason, really, that I really believed that I could do this. That chair is what got me to the table in the OR, in med school. I worked with the OR nurses. We figured out a way for me to scrub. We figured out, how I was going to get to the table and stay sterile. One of the things that Dr. Galpin had told me was the motorized chair is important because then I can move around the OR without having to have somebody move me, which I'm stubborn and, I don't want to depend on other people to do things like move around the OR. I know a stubborn surgeon is hard to imagine, but they're now recruiting more students who are disabled, and it's really because of the advocacy that these two did early on. When I found surgery, what I found is I really love pediatric surgery, and that was a chance experience with this guy, Dr. Ed Barksdale. He's a pediatric surgeon at CASE at Rainbow, and not only do I just love being around the guy, he's very charismatic. He's just like this. He's like this caring father type to everybody. And I was in the OR with him once as a med student, and he had a college, observer, me, an intern, and a senior resident. And he was teaching to everybody in the OR. Like, he found a way to connect to everybody on their level. And when I first talked to him, he didn't believe there was any reason someone who was disabled couldn't go into surgery. He, from the very start, it was just not even a question in his mind. He was the first person I ever scrubbed with. He helped to put together a video that I then submitted when I was applying for residency to show people how it actually works. He actually is still a big part of it. It's been 10 years, more than 10 years, I think, since I was on his service as a med student, and he and I still talk regularly. He texted me a couple of weeks ago to ask about interviews, and the guy is the president of APSA right now, the American Pediatric Surgical Association. So all this stuff going on, and he still checks in with people that he's mentored over the years. His letter is what got me, his support and his letter is what got me a chance at residency. My program director said it was, one of the best letters he'd ever seen. But I mentioned before that there's still this attitude of, it's not possible for people who are disabled. And while Dr. Barksdale was very supportive, there were other people at the time who said, this isn't going to work. I'd be too worried about if there was a code, how are you going to get from point A to point B? What if the elevator's out? Well, sure, that's a valid question, but I have yet to be in a hospital that doesn't have 50 elevators all over the place. And if one of them's out, you just go to another one. So, and the other thing is, in a code, usually it's not the surgeons who are the first people to show up there. So it really has turned out to not really be an issue. And I actually just found out one of my letters for fellowship this year, somebody said, if you're worried about him getting somewhere, he's actually going to get there before everybody else, and he's not going to be winded when he gets there. So, so that's, I'll thank, I think that was Dr. Herschel here at Michigan who wrote that. So, but another surgeon at the time, I won't say which institution he was a part of, but he was a senior person who had a fairly established career. He compared a disabled resident to how he would used to think about women and being worried that they might leave for pregnancy. And to hear this in 2010 was like mind blowing to me. But those are, people give excuses when they're looking for reasons to exclude someone and not include someone. So I sent the video around. I went on interviews. Some places, like I said before, didn't ask the question. They didn't ask, how are you going to do this? How are you going to do that? To me, that always seemed very disingenuous, and that they weren't taking me seriously. Maybe they were scared of being seen as discriminatory. There are these questions we're not supposed to ask. We're not supposed to ask about, family planning and things, because those are things that people do, and you can still make it work. So I think it's a real disservice to not ask questions about disability, though. Having that dialogue is the most important thing. So the first time I applied for fellowship, I even found out there were places that interviewed me just to meet me, and they couldn't envision how a disabled person could be a physician, even after I met them. There's a story that a friend of mine likes to talk about, which is that he was in charge of disability services, and he heard a story or a complaint that someone had said, why is that we need to get rid of that disabled parking tag in the physician's parking lot? It must be a mistake. Couldn't possibly be a disabled physician. This is another person who is an advocate for me. This is Eric Lazar. He's my program director in residency. He was direct. He asked all the questions when I interviewed. He took me seriously. The AAMC did a report on disability a couple of years ago, and that stresses an openness to disability in admissions, physician mentors, and a top-down commitment. And Dr. Lazar put that into action. He said, look, if you tell me there's a bathroom that you can't get into because the doors aren't wide enough, I'll have maintenance in there a day later knocking the wall down. I did make it. This is a photo from July 1st in my intern year, doing my very first case as an intern. Funny enough, one of my last cases was with that same attending too at the end of residency. My story, I think, is because of a lot of the success that I've had is because of mentors that I've had and because of advocates that I've had, and people willing to go the extra mile and ask those questions and make things happen. And that's the reason I think that I've been as lucky as I have been. So I will show you the video that kind of helps to sort of put everything into perspective. This was shot in residency. This was actually done for one of the television interviews that we had done. So it's funny, whenever we're recording these things, they're very staged. But so that's gowning up in the OR. The chair actually, the gown goes around me. It goes around the entire chair. And then what I'll do is, I'll have the circulators tie the gown around the back of the chair. And then we take another 3/4 drape, which is kind of like a sheet, and wrap it around my waist, and they clamp it behind the chair so that you can, it basically covers everything. And then it covers the controls so that I can move around the OR once sterilely and not have to, depend on somebody to pull me around to the other side. There, that's the whole sort of get up in place. I don't remember what case. This was just a little small toe case. That's Dr. Lazar, my program director. So, and then I continued on to Columbus. These are two people in Columbus who are just fantastic mentors as well. That's Gail Besner on the left, who's the chair of pediatric surgery, and then Karen Diefenbach, who is my program director at the MIS Fellowship. Same thing. They met with me. We had open lines of communication. We figured out ways to simulate stuff, and they've been huge advocates. I mean, to this day, I get comments on Dr. Besner's letter in my fellowship application and how it's, the best letter people have seen from her. And she also is one of these, internationally renowned pediatric surgeons. So I've been super, super lucky in the people that I've had. And then, of course, save the best for last. Here coming to Michigan, we've done a lot of simulation here. The bottom photo is with the two other Ped Surg critical care fellows. The top left, we've done a lot of simulation around the NICU as to how to make things actually work. We've figured out how to rearrange the isolette so that I can actually get underneath it, as opposed to having to lean over it or awkwardly lean from one side to the other. I've been able to, I've intubated more than 20 people and done procedures at the bedside in the NICU. We've done XLAPs, placed chest tubes, pretty much anything anybody could do. And on the right side, the very right side of the screen I'm doing an appendectomy with Corey, who's the senior fellow. He's just holding the camera. And Dr. Newman is the one actually taking the video. So, and then the top is in the middle is operating with Dr. Herschel. So, the faculty here have just been unreal. I mean, I think the commitment to disability at Michigan is unlike anything I've seen anywhere else. And it's the whole department here that's been really awesome. I do want to just make some points about sort of the things that I think are important in my journey, and I think it's important as far as advocacy for when working with patients and with other people in health professions. I think there are a lot of people who've come into roadblocks, and there's still a lot of places that just say no and don't even entertain the possibility of working with students or learners who are disabled. And I know I want to sort of share things so that you have an idea of what the challenges people are facing on a daily basis and just sort of how prevalent in general ableism is and in the language that is used. I think language is important. It sets the tone for a lot of conversations. I think, disabled is okay. Most people are going to be fine with using that as a word. People tend to shy away from handicapped. I think that, everyone's different, but there's a lot more people I've met that are comfortable with the term disabled. Definitely, avoid terms like wheelchair bound. Things like that are terms that focus more on the limitations. And a lot of people view their wheelchairs and their adaptive equipment as actually liberating and being able to free them and give them the ability to live their life rather than limiting them. A lot of people don't like the term special needs, just with respect to disabled. Let's see. Oh yeah, don't use the term suffering. It's just in general focuses on the negative aspect of it. Is it not, it's not a walk in the park. It's not fun. I'm not going to say, having a disability is great, but I don't feel that I suffer. At this point, the first few years of adjustment and adaptation are difficult, and it's learning how to live life again in pretty much every way. But, this is not a suffering kind of experience. Most importantly, it's okay to ask. I've heard so many stories from people going to a physician's office and the physician speaks to an assistant who's with them or another person who's in the room, as if the person who has a physical disability can't communicate. And I kind of do the same thing with children. I speak to the kids until they sort of show to me that they don't want to engage in conversation. And even if a parent asks me a question, I look at the kid and I speak to the kid. And you actually see they're a lot more engaged that way. I hear stories of people going to restaurants and the waiter or waitress will talk over them at the other people around the table. There was something I was going to add to that, but I forgot. So it's an individualized approach, and it's okay to ask. It's okay to ask what terminology to use, how their people's disability affects them, how they cope, what challenges they face. And the other thing I always hear people complaining about is physicians assuming that all of their problems are related to their disability. I've had a lot of people whose symptoms have not been taken seriously. I've heard of many people who haven't received counseling and sexual health and wellness because they assume that they're not sexually active. There are logistical things that are important for providing care. Doors and hallways have to be wide enough to accommodate equipment, service animals, additional people who may be present with them, exam tables that have adjustable height, exam rooms that are big enough. You'd be surprised how many older offices and hospitals have tiny little rooms, even in healthcare. Our ER in Mott is pretty darn small. And if I go into a room, I almost can't close the door in the ER in Mott. I either have to have the parents or a nurse shove the bed all the way to the side and then go in, and it's a big sort of ordeal. And Mott's not an old hospital. I had an experience in med school where if I was going into clinic with one of the attendings, if we were in about half of the rooms, he would have to ask if the patients were okay leaving the door open because I couldn't come in and close the door. So bathrooms are always an issue. And then just remember, not all disabilities are visible. Even I sometimes have to remind myself of this. The main thing really is listening to people. This was a quote that somebody, when I reached out to people, had asked. I wish medical students were taught to be open to the information that disabled patients provide. It's okay for a med student or a doctor to admit that they don't have the answer. That's so much more helpful than gaslighting the patient. And that's just something in general. It's not bad to say to a patient, I don't know, as long as you follow up with, but I'll find out and I will get back to you about it. There are people at all different stages of their career who I've seen do that, and patients will respect you for saying if you don't know something. I've talked before that, or in the past, that disabled patients are experts on their own bodies. This is Jerusha Mather. She was in Australia. She has cerebral palsy. She had been fighting for years with the support of physicians to try to take their sort of MCAT equivalent and to take it for a longer period of time. She is fatigued. She normally has double the time for her exams. And she requested, as usual, to double the time, and they gave her an extra 25%, and that was it. Universities told her to consider different careers. She's currently doing a PhD in neuroscience and is still trying to take this test for entry to medical school after years, and she still hasn't been able to. So we're in a position to provide documentation and be some of the strongest advocates for these people. But at the same time, sometimes there's a lot more to it than just what we can do. I'm pretty active on Twitter. There's a lot of threads and a lot of people commenting on this stuff in general. And some of what is out there, I think, is really helpful. There's one thread basically looks at terminology to use to avoid sort of gaslighting patients and to make them feel heard. This sort of again touches on what I mentioned. Don't say you can't have those symptoms at the same time, or that's not possible, or just instead just say that must be uncomfortable, or I'm sorry, or in your experience, what has helped? Dealing with which of these things has helped. When your blood work or imaging is normal, so you're fine. Well, one of the things to say is, I know it can be frustrating when tests don't give answers, but we're going to keep looking for them together. I've always used kind of a variant of that myself, which is with patients is, look, we've looked for this on imaging and we've looked for this in blood work, and we haven't found X, Y, and Z. I know that's really frustrating, and we don't have an answer, but it means we've ruled out these other things that are really bad. So there's at least a positive aspect to it in that. I don't want to read everything here verbatim, but just, not ignoring or downplaying people's pain. Don't ask people about accessibility or what their needs are, or if they need, accessibility equipment, durable medical equipment, stuff like that. Just don't be dismissive, basically, just, hear people out. It really is all just about communication. So one of the things as far as advocacy is always, understanding the community in general. It's really important to learn about a group if you're able to be an advocate and to provide care for that group. you know, like a lot of people, I didn't know anyone who was disabled until my own injury. My friends didn't. This was all a new experience for all of us. I didn't know the day-to-day challenges and things that people face just trying to do little things like going out with a group of friends, you know, dealing with accessible entrances and accessible bathrooms, thinking about transportation. In New York, the buses are accessible, but not all the subway stations are, and half the time the elevators don't even work. So it's not just, you know, having to go somewhere becomes a big ordeal. You can go down a rabbit hole of challenges. You know, my program director in residency saw me getting out of my car one day in the parking lot and figured he'd wait and we'd walk in together. And he said afterwards, he didn't realize just how getting in and out of a car is much more, you know, complicated than just what he would have thought. So there's a lot of ways to understand the experiences people have, understanding the community in general. I'm big on, you know, I think Twitter, YouTube, TikTok are great resources. You can get a chance to just talk to people. A lot of people are willing to share their experiences. A lot of people don't want to, and that's fine too. But online, there are a lot of people who are very vocal about their experiences. And so, you know, whoops, just sort of thinking about it yourself too. This has opened my eyes to not only my own disability, but other challenges that people face in general, diversity and equity in general. And there's a lot of marginalized groups that, although we're not a member of, as physicians, we need to be able to provide care for them and understand what their challenges are. I think it's essential, like I mentioned before, for people to see other people like them. In my case, what really drove it home to me was seeing another person who was a surgeon who used a wheelchair. And I was comfortable asking him questions and talking to him. Like I said, I think this applies to all groups, not just disabled patients. There's a thread here. I'm trying to compress for time because I have to take this exam. But the core of the thread is a patient who was being rounded on, and the group sort of explained and gave him a diagnosis of MS. And they didn't really explain to the patient. He just said, okay. And one of the people on the team went back afterwards and asked him, you know, did you really understand what happened? And he said, no. And they had a long conversation about it. And what it amounted to was the patient, who was a Black patient, didn't feel comfortable asking this whole group of doctors. But when he had somebody who came back and talked to him who was also Black, he felt a lot more comfortable, and he actually engaged in the conversation, and somebody who he felt was actually listening to him. And that's the important part, is that people feel heard. So listen to patients. You know, there's a couple quotes in here from people that I've gotten from people. As a disability activist who's proud of being disabled, there's a vocabulary of identity that I can't use with doctors. They think disability is bad. It's what they want to keep you from becoming. With a disabled doctor, I wouldn't have to explain so much because we're speaking the same language. My care outcomes would be so much better because I would be understood. You know, I mentioned before about access to sexual health and reproductive health. This was a recent example that somebody had posted online. This is Heather, she's a social worker in Philly. And she went into an office and the nurse said, so are you sexually active? And then she looked at her and laughed and said, I guess no, considering. And so this is, you know, this is very, very commonplace. I am running short on time. This is Dinesh Palapana. He was a med student. He reached out to me years ago, who also had a motor vehicle accident. And he had all this praise that he got as one of the most highly skilled students his med school has ever graduated. And they still wouldn't let him sit to take, you know, his exam to sit and, you know, enroll for residency. So this is still a challenge in a lot of places. Part of the issues that I see are just the stereotypes, the stigma, peer attitudes, and the clinicalized culture in general, in sort of interacting with people who are disabled rather than speaking to them as the person. A lot of times people will speak to them as their diagnosis. And this sort of has led to a lot of restricted views. And for learners, these were some points that they had identified in the AAMC report. This has led to learners being counseled out of specialties, as I have, as a lot of people have. And this last thread, I'm gonna, you know, I know you guys will have the recording and I'm happy to share the slides, but this gets into a lot of just concerns and thoughts people have about etiquette, not touching anyone's wheelchair unless you're asked, I had somebody try to do, actually, I had an experience in med school where I was crossing a bridge to get to school, and somebody saw me, going up the hill, and it wasn't a huge steep hill. And he said, "Oh, do you need help?" And I said, "No, I don't need help. I'm fine. Here, let me help you." "No, no, no, I'm fine." He said, "No, no, no, I'll help you." And he grabbed the back of my chair. So I grabbed and locked the wheels with my hands and basically said, "I don't need help." And I was very stern with him. Well, a week later, he was the attending whose service I was rotating on. But he actually came up to me and he said, "I want to apologize. I really thought about the experience after that. And I shouldn't have done that. I invaded your personal space." And so he realized it, and we had a good conversation afterwards about that. Some of the points in here are similar to what I've mentioned before, which is don't talk over people, speak to people, ask them what their needs are. Even after people are out of their chair, if they've transferred to an exam table, don't move their chair, don't touch things. People see it as an extension of themselves. And then again, use the word disabled, don't say wheelchair bound, don't say confined, and just treat people like you would anybody else. That's kind of the main thing. I think to summarize, most important things: fostering effective communication, engaging people respectfully, listen to what they have to say, and don't come into each situation with any assumptions, because everybody is different and everyone's experience of disability is different. So I want to thank you guys for the chance. I did try to save a few minutes so we can do some questions if anyone has any. And I see my buddy Farron has signed on as well. So how's it going, man?
Yeah, thank you so much, Dr. McCulloh. This has been awesome. Thank you so much for your time and for coming to speak with us. I did ask for some questions beforehand. So just one question if you have time for that, and then we can see if other people have questions. But just really briefly, do you have any major advice for current medical students with disabilities going through their medical training?
I think the main, my focus is certainly on, has always been on surgery in general, just because the logistic aspect of it, it's a physical specialty as opposed to some of the others. Same thing would apply to emergency medicine and other things. I think if there are concerns, what worked for me is to have the conversations with people early on. So engaging people who are very senior. I was talking to people about my surgery rotation probably about a year before I actually did it. So we engaged senior nurse leadership, we engaged the clerkship director, and all of these, and everybody who had a role in overseeing these to say, how are we going to make this happen? And I think that's really important because each individual is going to know what their needs are relative to going through rotations and that. I think that's probably the most important part. There are very few resources for this. There is a textbook that came out a couple of years ago, which several people here have written a part of, including myself, just about health professions and disability as diversity. And I think that's a good resource to look at. I think that's a particularly good resource for clerkship directors and for people who are in leadership positions, because it gives them a chance to think about these things ahead of time and to see what resources are out there and what questions to ask of the learner. I think from my own perspective, I think it's important. It was important for me to be an advocate for myself, but I think not everybody is going to take the same position, and some people it's going to be harder for them to do. So I think it's sort of incumbent upon us to engage those people ahead of time. But it's hard to know, people have to be advocates for themselves. That's a lesson that I've had to learn, and I still have to learn. When I'm in the OR and I'm doing a new procedure with a new attending, I still have to go to the table with them beforehand and say, no, I have to do this a little bit differently. How do we approach this procedure? Because I can't stand in the same way that somebody else can stand. So I think it starts with the individual themselves having an honest, conversation with themselves, so that they can figure out what they do need and advocate for that. I don't know if that helps, but
yeah, that's super helpful. Thank you. I know you have to leave very soon. Are there any other questions that people have who are on the call right now?
Yeah, I'll jump in. Dr. McCulloh, I'm Eric Middleton. I'm one of the counselors to the medical students. Thanks so much for your talk. Really informative. You made a comment, Dr. McCulloh, about your before your accident, you'd feel like you'd rather die rather than be disabled in a wheelchair. How where have you come since then on that perspective, and how can you help the rest of the world that feels that way and has that perspective?
Yeah, thanks for that. I mean, that is, I think that there's a lot of people who probably have that same thought, and it was something that I certainly don't feel that way now. And I think that that was sort of my immediate thought, and I think that and I share that with people just so that they just try to normalize that feeling, and that it's okay to feel that way. I think that's a normal reaction to that kind of trauma. Is my whole world is potentially changing in an instant, and I don't know how I'm going to do this change. I think that now certainly I am very happy that I didn't die, and I think I'm very fortunate. I often think about how fortunate I am that my injury wasn't slightly higher. There was a guy in rehab with me who his injury was one vertebra higher than mine, and he was up and walking in rehab. It took me almost a year before I was able to stand on my own. He was up and walking, and he was doing great, and I remember being jealous of him. But because his injury was a little bit higher, it affected his phrenic nerve, and he needed respiratory support. He even had a little portable CPAP machine and ventilator that he would wear. I found out 6 months after we both left rehab, that he had died from a pneumonia. And it sort of it put into perspective that a few centimeters one direction or the other could have drastically changed the outcome. And I've sometimes thought, well, my injury was at the lower part of my neck. If I landed a few centimeters lower, I probably would have had sore shoulders, and that would have been it. But if I was a few centimeters higher, I could have wound up in the same position with diaphragmatic issues, and I could have died. And I'm incredibly happy with where I am now, and with what I've been able to do. But I think it's okay to feel those feelings in the beginning, and I think it's normal, and I think it's so I think just my thing has always been to tell people that it is okay, and that it is normal, and that what they're feeling is the same thing that I felt, but it does get better. So.
Yeah, thank you for that response. And thank you, Eric, for the question. I understand. I'm going to let you go now.
Yeah.
But if other people on the call have questions, feel free to send them to me, and I can pass them on to Dr. McCulloh. We can figure something out that way. But again, thank you so much, Dr. McCulloh, for joining us today. Thank you to everyone who came, and I hope you have a great rest of your day.
Yeah, thank you guys very much. And like I said, you can reach out to me on Twitter, direct message, or email through the university. I'm happy to speak to anybody. So, and I hope to see you guys all. Well, I know some of you are fourth years, and good luck next week. For the rest of you guys, I hope we see you on pediatric surgery. So.
Thank you.
Thank you.
Thank you.
Good job, KP.
Okay, let me end the recording.